You're welcome to my YouTube channel, Next Connect Institute. In this session, we shall consider a topic from the gastrointestinal tract or the system or the digestive system. And basically, we will focus on peptic ulcer disease. By definition, peptic ulcer disease is defined as an erosion of the gastrointestinal mucosa, which will basically result from the digestive action of two products, number one, hydrochloric acid and pepsin. That's one definition that we can fall on. I should also emphasize that peptic ulcers or peptic ulcer disease will actually be an ulceration of the gastrointestinal tract on three distinct portions. Number one, the lower portion of the esophagus. Secondly, the stomach itself. And thirdly, the distal part portion of the duodenum. It's important to also note that peptic ulcer is basically an excavation that is formed in the mucosa wall or the esophagus, the stomach, or duodenum, the three critical areas. I should be quick to mention that each one of you listening or watching this presentation, you should demonstrate the ability to draw the stomach, indicating the sites for ulceration. As we continue through our presentation, you take note of the particular diagram that you should pay attention to. On the epidemiology, it is worth noting that the frequency of peptic ulcer diseases, it's actually between 40 and 60 years, and the peak age for particularly duodenal ulcers is between 30 to 60 years. Then the peak age in gastric or stomach ulcers is 50 years and above. Then with regards to the ratio between men and women, and that's to focus on duodenal ulcers, it is 2 to 3 to 1. So meaning it is more common in men than in women, and that is duodenal ulcers. Then the ratio of male to female in gastric ulcers, it is equal, that is 1 to 1. In particular interest, it's also considerable that 80% of peptic ulcer disease is duodenal in nature, and only 15% is gastric. You also take note that particular interest usually focuses on duodenal ulcers and gastric ulcers because these are the most common ones. The common sites for peptic ulcer disease, as I earlier alluded to, include the lower portion of the esophagus, the stomach, the proximal portion of the duodenum. This is a particular diagram which we need to draw, and ensure that as you draw this diagram, you indicate all sites. We have the fundus, we have the greater curvature, we have the lesser curvature, we have the pyloric sphincter, all that. So it should be identified and labeled correctly. The types of peptic ulcer disease usually are classified according to the degree and the location of a particular ulcer. Now, with location, we have basically, as alluded to, three of them. We have the esophageal ulcers, the gastric ulcers, and the duodenal ulcers. According to the degree, it could be acute or chronic. Acute meaning sudden, chronic meaning over a period of time. We'll start with esophageal ulcers. Now, these are ulcers that affect the lower portion of the esophagus. And this is as a result of the excavation effect of the gastric contents once they escape the stomach. And this is usually attributed to the weaker esophageal sphincter. This is a sphincter that is between the esophagus and the stomach itself. So this will result in esophageal ulcers. Gastric ulcers usually occur in the lesser and the greater curvatures and usually around the pyloric antrum. The occurrence is due to defective ability of the stomach to heal faster. And usually this will be as a result of a weakened protective system. Duodenal ulcers are the commonest, and they are seen in the first portion of the duodenum. And these usually result from high secretion of one acid, which is produced in the stomach, known as hydrochloric acid. What could be the cause of peptic ulcer disease? Already, we have mentioned some factors which we may term to be predisposing factor. But of course, apart from this, there is one particular bacteria which is known as Helicobacter pylori, and this is present in almost 70% of patients who will present with stomach ulcers. And again, the same bacteria will be so present in about 95% of patients who have duodenal ulcers. On the predisposing factors, number one, emotional factors. Now, emotional factors, usually this could be related to anxiety, frustration, excessive levels of stress. This will result in an imbalanced autonomic nervous system, and it will eventually lead to increased vasodilation of the gastric secretion. So in the end, the vagus nerve, which elevates the stomach, will be highly stimulated, leading to excessive secretion of the digestive substances. Secondly, inflammation. It's worth noting that gastritis, which is the inflammation of the stomach, and trauma of the mucosa reduces the resistance of the membrane to digestion. So once there's this chronic inflammatory processes that are occurring in any sites that we have earlier mentioned, this will just compromise the ability of the body to protect itself from the digestive juices. Hereditary, it is worth noting that individuals that are particularly of type A and type O are prone to having peptic ulcer disease. Individuals that, of course, are of type group O, they will usually present with duodenal ulcers. Then individuals with type group A will usually present with gastric ulcers. For the sake of remembering, the two types of ulcers we are discussing is gastric, which sounds like letter A, and duodenal ulcers, which sounds like letter O. So you can easily remember that individuals with blood group type O will present with duodenal ulcers. Trauma and serious illness. Now, critically ill patients with particular interest on hypotensive patients and those patients that are having difficulties in breathing, probably they could have a respiratory infection. These will be prone to peptic ulcer disease. Reason because there will be insufficient perfusion of oxygen in body tissues, which will lead to ischemia, and eventually necrosis and ulceration may just ensue. Prolonged use of irritants. These irritants could be drugs, and an example are non-steroidal anti-inflammatory drugs, the NSAIDs, which of course will just predispose one to having this condition. The best example is commonly the aspirin, which is generically known as acetylsalicylic acid, and Indosit. These are grouped under the NSAIDs. Apart from prolonged use of drugs such as the aspirin, alcohol abuse, excessive abuse of alcohol may just inhibit the production of prostaglandin, and prostaglandin in this case, it's a product that is inhibiting the wearing off of the lining of the gastrointestinal tract. Bowel reflux, it's another predisposing factor. Normal aging, when one is aging, usually the pyloric sphincter, its effectiveness is reduced, and this will just end up permitting the deflux of bowel into the stomach. The last one is Odinger-Edison syndrome, which is of course characterized by excessive production of hydrochloric acid, which erodes the gastric and the duodenal lining. The epidemiology has already been covered. On the pathophysiology, it's simply put that when we'll have a decrease in the ability of the gastrointestinal tract to inhibit the action of the digestive juices, ulceration occurs. So I think this is so important to take note. In this picture, it is being demonstrated that when we have factors that protect against acidity being overpowered by factors that increase acidity secretion, then an ulcer may just form, which will be referred to as peptic ulcer disease. What could be the obvious signs and symptoms? Epigastric pain, the first one. Heartburn, the second sign and symptom. Thirdly, vomiting, weight loss, dyspepsia, chest discomfort, anorexia, hematemesis, Malena stool, constipation, and all that. It's very important that we also must, for the sake of our examination, especially in Zambia, you must this table, which differentiates between gastric ulcers and duodenal ulcers. We have characteristics that we are using to differentiate between the two types of ulcers. The first characteristic is location of the lesion or the ulcer. Under gastric ulcers, it's important to take note that this is predominantly in the antrum. It can also be found along the body and the fundus of the stomach. And under the duodenal ulcers, the location of the ulcer will be in the first 2 centimeters of the duodenum. Then how can we describe this lesion? Under gastric ulcers, usually the lesions or the ulcers will be superficial with refined smooth margins, could be round, oval, or cone-shaped. And under duodenal ulcers, the lesion may be penetrating and is usually associated with deformity of the duodenum from healing of the ulcer itself. Then the clinical manifestations, it's very important to take note of the following. Under the gastric ulcers, pain will usually occur between 1 and the 2nd hour after one has consumed food. This will just result in aggravated pain. Then under the duodenal ulcers, pain usually occurs after 2 to 4 hours after meals. Pain usually is relieved when one has consumed food, and therefore patients that present with gastric ulcers will have weight loss. Then patients that present with duodenal ulcers usually would have gained weight. Why? Because they find comfort in consuming plenty of food. Under gastric ulcers, we'll have hematemesis, and under duodenal ulcers, we'll have Malena. For blood group, in some literature, it indicates that there's no difference under gastric ulcers, but of course, under duodenal ulcers, this is common in individuals with blood group O. Cancerous tendencies. Under gastric ulcer, this is more common to result or develop into cancers. In patients with duodenal ulcers, they are less likely to have cancer of the duodenum, but those with gastric ulcers usually will have higher tendencies to develop cancer. Why? Because of the rate of the inflammatory processes. Under the management, we'll have to consider this discussion in the next session, which is part 2 that we'll have. For now, we'll end here, and thank you for watching and learning this important topic.